So, welcome to this lecture, ladies and gentlemen. I hope you are okay. We are still doing antihypertensives. We are still doing antihypertensives, and we've had a series of lectures on antihypertensives, and today we want to proceed with the antihypertensives and the category of drugs that we are going to look at today are what we call the directly acting vasodilators. Yeah. Remember, when you have vasodilation, then if you have vasodilation, especially on the venous side, then you will have a decrease in preload. And once you have a decrease in preload, then therefore you will have a decrease in stroke volume, and eventually you will have a decrease in blood pressure. And if you have a vasodilator on the arterial side, that means that you will have a decrease in total peripheral resistance. And because you will have a decrease in total peripheral resistance, you will therefore have a decrease in blood pressure. So today we want to look at directly acting vasodilators. And these directly acting vasodilators are divided into two. We have what we call the venous and arterial dilators. In other words, these drugs, like for example, nitroprusside, for it is able to dilate both the vein and the arterioles. Yeah, it's called nitroprusside. On the other hand, we have strictly arterial dilators. We have strictly arterial dilators, and the examples we have are hydralazine, minoxidil, and diazoxide. So these are examples of directly acting vasodilators. Now, you should know that these ones do not basically affect the sympathetic nervous system. No, for them they cause direct vasodilation. In other words, they have to do with the ion conductivity of ion conductivity within the vessels or within the veins or even within the arterioles. Yeah. So let us look at how these basically cause or bring about vasodilation. So assuming this is your blood cell, rather assuming this is your smooth muscle cell, assuming this is your smooth muscle cell, what actually happens is that minoxidil and diazoxide, remember we said those are arterial vasodilators. Minoxidil and diazoxide, for them, what they do is to open, they cause opening of, of potassium gated channels. They cause or they bring about opening of potassium gated channels. So if minoxidil is given, these potassium gated channels will open, and of course you know that potassium is an intracellular ion. I hope you know that potassium is an intracellular ion. So if these drugs, minoxidil and diazoxide, cause opening of potassium gated channels, what will happen is that the potassium will do what? Will exit. So you have potassium moving out. You will have potassium moving out of the cell, because it is an intracellular ion. Now, what does that make the cell? That makes the cell, remember the potassium is leaving, yeah? That makes the cell very, very electronegative. That makes the cells very, very electronegative. So the cell becomes very, very electronegative. And so what it will be very, very hard for it to be excited. So it would be very, very hard for the cell to be excited. Remember, for an action potential to take place, it basically the cell has to become positive within here. But remember, since it is very, very negative, yeah, since there is a region of what we call electronegativity, yeah, electronegativity, region of electronegativity. An action potential will find it very, very hard to excite this cell. In other words, to cause this cell to contract. Yeah. So basically, because of that, minoxidil and diazoxide, they cause relaxation of these arterioles. Yeah, because of the fact that they cause a lot of potassium to exit the cells, making the inside of the cells so electronegative, and then making it very hard for it to be excited. Yeah. So, or making it very hard for a stimulus to elicit an action potential within the cell. And therefore, because they are unable to, because it is unable to be excited, then it will continue dilated. It will continue relaxed. So that is basically how minoxidil and diazoxide basically bring about vasodilatation. Yeah. Now, hydralazine on the other hand, and nitroprusside, for them, what happens is that when they enter the cell, when hydralazine and nitroprusside enter the cell, for them they cause release of of nitric oxide. They cause release of nitric oxide, which nitric oxide we shall look at it more when we look at an angina drug. Yeah. But nitric oxide is a very, very potent, vasodilator. Yeah. So hydralazine and nitroprusside and hydralazine for them, when they enter the cell, when they enter the muscle cell, they call, when they enter the muscle cell extracts, it extracts nitric oxide from them. And this nitric oxide is a very, very potent, vasodilator. And so basically that is how they bring about vasodilation. And of course, if you have vasodilation, what does this mean? It means that you will have, as we said earlier, you will have a decrease in preload, but you will also have a decrease in afterload. And so you will eventually have a decrease in blood pressure. Is that okay? All right. So basically, those are the directly acting vasodilator, and that is how they do their function as far as regulation of blood pressure is concerned. The next group of drugs, or the next category of drugs that we are going to look at, are what we refer to as the calcium channel blockers. The next category of antihypertensives we are going to look at are what we refer to as the calcium channel blockers. The calcium channel blockers. So with the calcium channel blockers, calcium channel blockers. So basically, you know very well that for a smooth muscle to contract, there should be influx of calcium, you know, calcium. And so these drugs, when they are given, they block, you know, they block the entrances of, you know, of calcium to enter, and therefore, you know, the muscle will not contract. Yeah. So basically, when there is no influx of calcium ions, because calcium channel blockers have been used, then we shall not have, you know, we shall not have contraction, or we shall not have we shall not have effective contraction, because for muscles to contract, whereby the actin and myosin, that the actin and myosin relationship, it is basically facilitated by calcium channel, rather calcium ions. And if we give a calcium channel blocker, then we shall not have, you know, contraction of these muscles. So calcium is basically required for the contractility of the heart. Yeah, and I think you know that very well. We shall look at this more in antiarrhythmic drugs. Yeah, but you know very well that calcium is very, very essential in the, you know, in the contraction of muscles of the heart, but also the, you know, the blood vessels. Yeah. So so when examples of calcium channel blockers, basically anifedipine. Examples of calcium channel blockers are nifedipine, and of course this nifedipine basically blocks mainly works on smooth muscles. You know, calcium channel blockers, they are those that work on smooth muscles, yeah, or are more effective on smooth muscles, and there are those that are more effective on the heart, or the muscles of the heart. So if we are to subdivide them like this, let me do something like that, like this. You have the heart, and then you have the smooth muscles. So as far as nifedipine is concerned, it is more active. Yeah, it is more, you know, it is more active on the smooth muscle. So it causes much dilatation. You know, it is more active on the smooth muscles. Yeah, in other words, it causes it blocks the calcium ion channels mostly in the smooth muscles. Yeah. The other example, and of course, it does mostly here, but it also has an effect here. Yeah. It also has a slight effect on the heart. Yeah. The other example is what we call verapamil. The other example is what we call verapamil, and verapamil, for it has, you know, it has a more effect on the heart. Yeah. In other words, it blocks calcium channels mostly within the heart and less within the smooth muscles. And the other example is diltiazem. The other example is diltiazem, and diltiazem basically has an effect on both. Diltiazem has an effect on both the smooth muscle and the heart. Yeah. So these are the examples of, you know, calcium channel blockers of interest that are basically mainly looked at as far as you know, antihypertensives are concerned. And I believe you have seen patients who have had patients who have you know, who are on you know, calcium channel blockers. Yeah, nifedipine, verapamil, and diltiazem. And of course, we shall see that these can also be used in you know, as far as prevention of angina, yeah, and they can also be used as anti-angina drugs. But basically, their mode of action is, since they are calcium channel blockers, they basically block the calcium channels. And calcium is required as far as contraction or contractility of the heart is concerned, but also contraction or more constriction of the smooth muscles. And so if we give them, then therefore they will prevent one contraction of the heart, which will eventually lead to a decrease in, of course, blood pressure. But also, if we give them and they cause, they prevent contraction of the smooth muscles, again, that basically means that the smooth muscles will continue to relax. And so that will decrease blood pressure. Is that clear? All right. So the other category of drugs, antihypertensives, we want to look at here are what we call the angiotensin converting enzyme inhibitors. The angiotensin converting enzyme inhibitors. I think you've heard about the prils, captopril, lisinopril, those are referred to as angiotensin converting enzyme inhibitors. Yeah, they are referred to as angiotensin converting enzyme inhibitors. And basically, for you to understand the role of these drugs, these angiotensin converting enzyme inhibitors, or what we refer to as the SCIs, yeah, angiotensin converting enzyme inhibitors, yeah. So for you to really understand the role of these enzymes, rather of these drugs, you need to understand the role of what we refer to as the RAS, yeah, the RAS, the renin angiotensin aldosterone system. You need to understand the RAS, the renin aldosterone, the renin angiotensin aldosterone system. Yeah. So basically, I talked about this in the earlier presentation on hypertension, but we can still repeat it a little bit. Renin is an enzyme, yeah, that is released from the juxtaglomerular apparatus of the nephron within the kidneys in the distal tubule. Yeah. So when it is released, what actually happens when it is released from there? What actually happens is that it causes conversion of angiotensinogen. Now, angiotensinogen is freely circulating in blood, and it is basically manufactured from the liver or by the liver. Yeah. So renin converts angiotensinogen to angiotensin 1. Yeah, is that clear? Renin will convert angiotensinogen to angiotensin 1. So angiotensinogen is converted to angiotensin 1 by an enzyme called renin. Yeah. Now, this angiotensin 1 will further be converted by angiotensin converting enzyme, which enzyme is basically manufactured in the liver, in the lungs, in the pulmonary trunk of, the pulmonary trunk of the lungs, yeah? And so SCE, angiotensin converting enzyme, will convert angiotensin 1 to angiotensin 2. Is that clear? Angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. And once this angiotensin 2 is converted to, yeah, then it has quite a number of effects. Then this angiotensin 2 has quite a number of effects. Now, what are the different effects of angiotensin 2? What are the different effects of angiotensin 2? One is that angiotensin 2 is a very, very potent vasoconstrictor. It is a very potent vasoconstrictor. So it causes arterial constriction. It will cause arterial constriction. It will cause arterial constriction. And it will also cause venous. It will also cause venous constriction, or what we call venoconstriction. So it will cause that. Now, it also basically acts it also acts on the aldosterone, or rather on the gland. It's called the adrenal, the adrenal cortex of the adrenal gland. Yeah, in the zona glomerulosa. Yeah, so it acts on the adrenal gland, specifically in the zona glomerulosa, which is located in the adrenal cortex, to cause release of a hormone called aldosterone. So in other words, this angiotensin 2 will act on the adrenal gland, specifically in the zona glomerulosa, which is located in the adrenal cortex, to cause release of a hormone called aldosterone. Now, not only does the angiotensin do that, but it also causes, or it acts on the hypothalamus. It acts on the hypothalamus to bring about or to cause thirst. So now those are some of the effects of angiotensin 2. Angiotensin. Those are some of the effects of angiotensin 2. So it causes arterial constriction. It causes venoconstriction. It causes release of aldosterone, yeah, by the adrenal gland, and it also acts on the hypothalamus to cause thirst. Now, all these effects basically bring about an increment in blood pressure. Yeah. So, what is the role of angiotensin converting enzyme inhibitors? What actually happens is that the angiotensin converting enzyme inhibitors basically angiotensin converting enzyme inhibitors, they block the angiotensin converting enzyme, yeah, which we said is produced within the lungs. So the angiotensin converting enzyme inhibitors, they block the enzyme itself. Yeah, so they block the enzyme, the angiotensin converting enzyme, which we said is produced within the lungs. And so once it is blocked, therefore we shall not have angiotensin 2, which causes all these effects that we have talked about. And so if we don't have all those effects that we have talked about, therefore the blood pressure will not be high, the blood pressure will decrease. Yeah, so I hope that is very, very clear. But also the other thing that I had not talked about is that basically angiotensin converting enzyme also breaks down a substance called bradykinin. Angiotensin converting enzyme also breaks down a substance called bradykinin. And if you remember very well in inflammation, if you did inflammation, bradykinin basically is a vasodilator. Bradykinin is a vasodilator. So if angiotensin if angiotensin converting enzyme is inhibited, it will also not break down bradykinin, and so we shall have vasodilation, and therefore we shall have a decrease in we shall have a decrease in blood pressure. Now, the other thing you should know is you know what happens. Angiotensin converting enzymes, they lead to accumulation of this within the lungs. Remember, we said angiotensin converting enzyme breaks down bradykinin. Yeah, it breaks down. Not only does it convert angiotensin 1 to angiotensin 2, but it also participates in the breakdown of this substance, bradykinin, which bradykinin is a vasodilator. Now, if angiotensin converting enzyme is inhibited, it basically means that even bradykinin will not be broken down. So it will end up accumulating in the lungs. So if it accumulates in the lungs, this is whereby people who are on angiotensin converting enzymes, rather angiotensin converting enzyme inhibitors, they usually have cough. Yeah, so they usually have cough, and that is basically because of the accumulation of bradykinin within the lungs. Yeah, and also it is very important for you to note the issue of angioedema. Yeah, angioedema, because of the too much or extensive vasodilation. Yeah, so when we use angiotensin converting enzymes, we shall have angioedema because of the because of the dilatation. Yeah, because of the dilatation. So we shall have angioedema. So those are some of the side effects of using angiotensin converting enzyme inhibitors. And of course, we said examples. What are the examples? Those drugs that end up with prill. Those drugs that end up with prill, yeah? Like captopril, lisinopril, enalapril, esmopril, all those are called angiotensin converting enzyme inhibitors. Is that clear? All right, so that has been another category of antihypertensives that is usually used in management of hypertension. Now, the other example that we are going to see are what we call the angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers. Now, you should not be confused. Yeah, I want you not to be confused between angiotensin 2 receptor blockers and angiotensin converting enzyme inhibitors. Now, with angiotensin 2 receptor blockers, basically these drugs, they block the receptors where angiotensin 2 has to act. And remember, we said, I hope you remember the effects of angiotensin 2. Yeah, I hope you remember the effects of angiotensin 2. So with angiotensin 2 receptor blockers, they block the receptors where angiotensin 2 has to act. Is that clear? All right. So basically, and where are these receptors located? Remember, we said in the arterioles, in the smooth muscles, in the venous smooth muscles, the adrenal cortex, among others. So they basically block those receptors so that angiotensin 2 cannot act. And of course, if it cannot act, then what happens? then you will not have the effects of angiotensin 2. Yeah. Now, what are some of the examples? You have heard about those drugs that end with Saturn. You've heard about those drugs that end with Saturn, losartan, Simbata, like losartan, you know. And so those drugs that end with Saturn, you know, Saturn are basically angiotensin 2 receptor blockers. Yeah. Losartan, yeah, among other examples that you will see in the notes. Now, one important thing that I should mention about ACEIs and Arabs, yeah, and Arabs, we refer to this as Arabs, yeah. So Arabs, A-R-B. So one important thing I should mention about ACEIs, or the angiotensin converting enzyme inhibitors, and the Arabs, or the angiotensin 2 receptor blockers, is that they are teratogenic. Both of them are teratogenic, and therefore they are not used in pregnancy. They are not used in pregnancy. They cannot be used in pregnancy. Yeah, so you should please note that we never give them in pregnancy because they are teratogenic. I hope that is clear. All right. So the other example, the other category of antihypertensives we want to look at are what we refer to as the diuretics. Diuretics, and of course we shall cover more of these when we are talking about renal pharmacology. Yeah, we shall talk about more of this when we are talking about renal pharmacology. But briefly, we want to talk about diuretics as the other, you know, as the other examples or as the other category of drugs that are used in you know, in hypertension. Yeah. So basically diuretics we shall cover, as I said, we shall look at these more when we're looking at renal pharmacology. Yeah. But basically the diuretics that are of interest are usually the thiazides and the loop diuretics. Yeah. So diuretics are the other example or the other category of antihypertensives. Yeah. So, and of importance are the thiazides and what we also refer to as the loop diuretics. Example, like for example, Lasix, yeah, Lasix or furosemide, yeah. So basically, these basically, you know, initially, as far as management of that, they cause, you know, elimination, yeah. They prevent or they stop eliminate. They cause, they reduce absorption of or reabsorption of sodium and water, yeah. They reduce sodium and water. They reduce the absorption of sodium and water. And remember, if you remember very well what we said about total blood volume also has a clue or has an implication of blood pressure. So if these diuretics reduce, you know, the absorption of sodium and water, then therefore the blood volume will decrease, and so you will have a reduction in blood pressure. But as we shall talk about them in renal pharmacology, we shall see that for them, in the long run, they eventually cause vasodilatation. Yeah, we shall look at that more in renal pharmacology. But initially, Their role in antihypertension is when they reduce sodium and water absorption initially, but in the long run, they basically need to bring about vasodilatation. So basically, that has been the last category of antihypertensives, the last category of drugs that we use in hypertension that I felt you should know. But of course, we shall talk about it more when we are talking about renal pharmacology. Yeah. So basically, it is also very important for you to know that all those drugs that we have given, all those drugs that we have mentioned, all those drugs that we have mentioned, starting from sympatholytic, centrally acting agents, up to the diuretics, all those drugs that we actually mentioned, they are all used as antihypertensives, but you cannot use all of them at the same time. Yeah, you cannot use all of them at the same time. So it is very important to know that there are some that are combined. Yeah, there are combinations. You can use maybe you can use a diuretic, and also maybe a calcium channel blocker. Yeah, so there are combinations. You see more of that in the notes. There are combinations of these categories, but you cannot have there are some that are never combined. There are some that are never combined, and there are those that are combined. And also, there are what we call first-line drugs. First-line drugs, like for example, diuretics. Diuretics are the first-line, drugs that are usually given as far as hypertension is concerned, because one, they are relatively cheap, and usually they are relatively tolerated by by almost every age category, especially even the elderly. Yeah. So within the elderly, you can basically give diuretics, or you can give SCIs, or you can even give calcium channel blockers, because they are easily tolerated. Yeah. So that has been the presentation on antihypertensives, and so we have looked at all those categories of drugs, yeah, that you usually give as far as hypertension is concerned, yeah, and in the presentation you'll see the combinations, the different combinations of drugs that are usually given as far as hypertension is concerned, and those that can never be combined, yeah. And also in the presentation that you'll get, you will see you will see more side effects and more, what we have concentrated more on this in these lectures is basically the mechanism of action. But you will see more of the adverse effects, in the presentation that you will get. Now, lastly, before we finish up this topic of hypertension, it is very important for you to know about what we refer to as hypertensive emergencies, and what you are supposed to do in a hypertensive emergency. So I'll basically say that someone is said to be in a hypertensive emergency if the systolic blood pressure is basically greater than 210 millimeters of mercury, and the diastolic blood pressure is greater than 150 millimeters of mercury. In what we call an otherwise healthy person. Yeah. So if someone comes to your unit otherwise healthy, they come to your unit and the systolic blood pressure is more than that. Yeah. And then the diastolic is basically greater than that, then they are said to be in a hypertensive emergency. They are said to be in a hypertensive emergency. They require immediate attention. Now, But it can also be defined as someone with a diastolic blood pressure of more than 130 millimeters of mercury. When they also have other complications, yeah, with other complications, with other complications, of course, of the hypertension, yeah. Like, for example, complications like hypertensive encephalopathy, complications like uh, nephropathy as a result of hypertension, complications like hypertensive cardiac failure, So these people are also said to be in hypertensive emergency. Now, when you get such a patient in hypertensive emergency, you need to bring down the blood pressure from that high. You need to bring it down. But, and I stress this, this is very important, you do not need to drastically bring it down. Yeah? You need to do it in a chronological way. And when you're observing and closely monitoring this patient, we do not drastically drop, we do not drastically drop the blood pressure. Why? The reason is that when blood pressure increases, what happens within the central nervous system is that there is what we call auto-regulation within the central nervous system. So when blood pressure increases, what happens to the blood vessels? They tend to narrow. Yeah, they tend to narrow to kind of like prevent the too much extensive pressure. They tend to narrow. So when you drastically drop the blood pressure, what actually happens is that you will render most of this, ischemic, because most of the will no longer be supplied. Yeah, because you have drastically, dropped, the blood pressure, and yet the blood vessels were, had basically narrowed. So we do not drastically drop the blood pressure if the patient comes in hypertensive emergency. We need to slow it down slowly, closely monitor and titrate. Yeah, you closely monitor and titrate depending on the need. So in the hospitals, what we actually do is that we usually have an infusion pump. We usually have an infusion pump and a monitor. Usually these people are even managed in ICU. Yeah, so a blood pressure monitor together, or a cardiac monitor together with an infusion pump. Yeah, and so you need to closely monitor and titrate, yeah, depending on the need of this patient. And so we basically do not want a greater than 20% drop, yeah, in blood pressure. So the blood pressure should drop, slowly up to a certain level, yeah, up to a certain. Our main aim is not to drop it, to the normal. No, our main aim is to drop it maybe not more than, or not more than not more than 20%. And actually, what the drug of choice that we usually use is sodium nitroprusside. The drug of choice that is usually used is sodium nitroprusside. Sodium nitro sodium nitro. I hope you still remember where this one was. Yeah, it was among the the vasodilators. Yeah, the directly acting vasodilators. So sodium nitroprusside is basically given by a continuous infusion. It's usually given by a continuous infusion using an infusion pump. It's usually given using an infusion pump, and it's usually a drug of choice because it has a very short half-life. Yeah? It has a very short half-life. And so However, if this is not present, then labetalol, yeah, labetalol. You still remember beta blockers, labetalol, yeah. So labetalol, which is both a beta and alpha blocker, yeah. Labetalol is also given in hypertensive emergencies, yeah. So basically, that concludes the end of a series of our lectures in antihypertensives. Next time, when we meet again, we shall talk about anti-anginal drugs. Thank you so much. Don't forget to send me an email, or don't forget to send me a WhatsApp in case you have an inquiry, or in case you have a question. Of course, we shall have live lectures. We shall have live lectures, but at the moment, let's dwell, or let's concentrate on these recorded lectures. So that basically marks the end of our antihypertensives. Next time we meet, we shall talk about something else. Thank you so much.